Platform Development and Utilization. Please welcome Dr. Maloney.
Well, thank you, Dr. Harper, and I'm glad to be here. Happy New Year for those of you who are in the room and those of you who are viewing remotely. I think Sarah Olson just told me that there's over 1 million viewers on Zoom, which almost doubles what's in this room so far. I know you can't see everybody, but it's standing room only. They've even occupied the wheelchair space because that's what they want to do. They came to see me. So you might be asking, why is the Chief Quality and Clinical Transformation Officer, who was formerly called the Chief Clinical Officer, and who was recruited 326 Fridays ago as the Chief Medical Officer to Children's, talking about data analytics? And while I was in the shower this morning, where I do my best thinking, I said, well, I need to give you a little bit of context. And so I'm going to take you back on a different journey, and that journey is going to start in 1992. I was a second-year pediatric resident in Salt Lake City, Utah, the University of Utah and Primary Children's Hospital. It was a relatively new hospital. We were the first intern class that started in 1990, and my department chair said, Maloney, I think you got a little bit of something in you, and I want to put you forward to the Pediatric Scientist Gesundheit, the Scientist Development Program. It was a collaboration between the American Medical School Pediatric Department Chairman, so all the chairmen throughout North America, and the American Board of Pediatrics. They got together and they said, hey, we want to train the next generation of scholars. And in order to do that and compete with the postdocs, the Ph.D.s, we need to give them a lot of time to spend in the lab and not as much time to spend in the clinic. So the fellowship programs were set up as 2 years of science work and 1 year of clinical work. So I ended up interviewing and put together a proposal to work in a molecular biology lab, and I ended up getting accepted. So in 1994, I started in a molecular biology lab, chasing down the way that COX-2 was being activated in neutrophils. Never been done before. And after about 8 months, I got an experiment to work, which was very frustrating, but then identified that the central dogma did not actually live in neutrophils. There was already RNA hanging out in neutrophils, ready to make a protein into COX-2. And so that was pretty cool finding. We got Scoopto, a Japanese lab, published that first. And after about 6 years, I said, man, I do not see anything that I'm doing right now in the lab is going to make any difference. And I can tell you, 30-something years later, COX-2 is dead. So I did learn some techniques. And by the way, if you want to learn about molecular biology and the cool stuff that's going on with CRISPR, read the book, The Code Breakers by Walter Isaacson. It is a phenomenal book. It'll teach you a lot of stuff and really about what's going on right now. So in 1999, I said, I got to do something different, and I decided to apply to graduate school in biomedical informatics. And in doing so, I wrote a grant to the National Library of Medicine to build a artificial intelligence tool to manage children on the ventilator. I was working at Intermountain Healthcare. They were a pioneer in informatics. They had originally built one of the first EMRs called HELP, Health Evaluation Through Logical Processing, and they were getting ready to embark on HELP 2. So the second generation of that, first generation was all DOS-based. The second generation was going to be a graphical user interface. And they didn't have a rules engine. They didn't have decision support in this new system. And so they took my project on, which was weaning children from the ventilator. So we had to assimilate information from the ventilator, from the monitors, vital signs and that's the kind of stuff, saturations, the lab and the pharmacy, put it through a rules engine and alert the doctors and nurses on what knob to turn on the ventilator. And what we found is that in 2003, when we did the study on about 40 patients, the ones that followed the protocol were off of the ventilator a day faster than those who didn't. And so that seemed like it was a great thing to do. That was in 2003. Fast forward to 2023, and we don't have that technology here. So I'm going to take you on the journey of how we're trying to get there at Children's since 2017 when I arrived. We have plenty of time. If you have questions, I'm happy to answer them as we go along, or you can hold them and we can talk afterwards. All right. That button didn't work. Okay, what's going on? Now I got to use this one. No, it's frozen. So Kelly's going to help us unfreeze.
Sometimes we just have to click. Now try your clicker.
All right. So currently I have no disclosures. That may change in 2024. My horoscope yesterday said great things are going to happen. I don't know what that means. So what I'm going to take you through this morning is our journey to move from a siloed organization of data to a single source of truth. Demonstrate how we move from manual to automated reports. We're going to talk about the tools and the processes that we can do for that. And then I'm going to end with the future and where we're going. The future has been going on now for at least a couple of years, 18 months for sure. And we're that close. We're that close to getting something in real time. And so we'll talk about that information. Here's our agenda. I like this cartoon of the big telescope having a black hole eating a star. That's what the pictures that came back. So I'll define the problem, define the solution, how we developed the solution, implemented it. We'll discuss the successes. So we built all the stuff that we're talking about by use cases, which means we either had a tool out there or somebody came up with an idea and we followed it, and then I'll end up with future opportunities. All right, strap in. So when I arrived on October 1st of 2017, I started asking questions about reports and data, and what I found out by November was that you could get data from 4 entities in our organization: performance improvement, now called quality and patient safety, information technology, strategic planning, or finance. You could ask all 4 of them the exact same questions and you would get 4 different answers, and every one of them would say, it's the truth. We guarantee you this is the right answer. Because there was a lot of assumptions, there were multiple data sets that people were using, and we couldn't join them all because they were all disparate, which was a big bummer for a data scientist coming into this organization. Back then, a lot of decisions were made from a top down, and I wasn't at the very top. So I had to do a lot of negotiating over the course of months in order to come up with this solution, which was we needed a separate analytics department. We needed somebody that was really smart that could run that. We needed to find out what data sources people were using to make decisions. We need to put the report writers, the business intelligence folks into that department. And we needed a electronic data warehouse. This is a place that can consume all kinds of external sources of information, can join them as you need to, and then provide a report of information that is actionable. And so that was accepted by the organization. And then you got all the HR stuff, putting together a department. And so here we go. We started then in 2019. I hired Maloney Garcia, the best hire I've ever made. Apologies to those who I've hired also, but this guy has made our analytics platform. And we'll go through about that. He was hired in January. We created the Care Transformation Department, and we moved the business intelligence folks in April of that year. And the first thing I asked Maloney to do is go out there, talk to all the stakeholders of data, and find out how many databases do we have. And he came back to me in May and he said, well, so far, Dr. Maloney, I found 110. Oracle being one, Epic being one. Those are huge things, right? But they're just one. And we had 110. I said, we got a problem. We need to get our arms around this. How are we going to make these decisions? And so we put this RFA out for an analytics engine. We had 5 companies that responded. We whittled it down to Health Catalyst and Epic. They came in July of 19 and presented to the executive committee. of how things were going, and executive committee was really excited until they got to the very last slide. And what was the very last slide? It was, how much is this going to cost you? And it was somewhere between $5 and $7 million over 3 to 5 years. So in August, they said, maybe not. Maybe not. Why don't you build this, Chris? You've assembled a guy. That was our team. Why don't you build this internally? So who's done this before? Well, not very many people. But Rona and I thought we could do that. So we set out to build our own electronic data warehouse. And where we started, we got lucky that the HIMSS, the Healthcare Information and Management System Society, HIMSS, they have an adoption model for analytics maturity. And the very first tier of that is about data governance. And so we use that as our roadmap. This was our roadmap. And you can see down there at the bottom, this says fragmented point solutions. So we got to start at 0. We were starting at 0. We knew we had fragmented point solutions. And how do we move up? Well, you move up with data aggregation and data governance. And like I said, we started with data governance. So what is data governance? It's the formal authority, it's the processes, it's the procedures to optimize your data management. And that's very important that you start with that foundation, right? If you're building a house, the important part of that house is the foundation. This is our foundation. And it really requires consistency, and it requires a lot of diligence. And so one of the frameworks around data governance is data dictionaries. And you will not see during this presentation, but in every one of our projects, we start out with a data dictionary. Where are we going after? Where does it live? What is the value? What is the units of measure that we should be getting back? And then what's the value, and is it valid? And so we have to have key stakeholders and stewards of that data as well. 3 main, very simple goals, right? You need to have data quality. There has to be data literacy. How do we use this data? And then you use it for information. And so the quality part was using the data stewards, and then we had to figure out how do we store it. Why at Children's? Because we needed that consistent version of the truth. We had not, up to that point, had good policies and processes on how we defined data quality. We had 110 different places people went to build their own reports to give them information. We needed to centralize that stuff. We needed to have better data communication and training. We needed to have better ownership. And finally, we needed a scalable, cost-effective solution. Data governance, but also at tier 1 or stage 1, is data aggregation. And what does that mean? How do we pull data together? And this is where we started getting use cases in the organization. What are we doing that we can be more efficient? And we just went out and we asked people and we surveyed. We were using this tool called ClickView. And ClickView was a very kludgy software tool that only one person in the organization knew how to use. And when one of these reports broke, you'd go to Jared, and Jared would say, well, that's going to be really hard to fix. I don't remember because he didn't document anything. He doesn't work for us anymore. Not because he didn't document anything. He found a job that was more suited for his personality. But we would put all this stuff together in a spreadsheet, one of those great tools, and then we would pick them off. We'd assign leaders. So you might see on the very top one up there, the requester is our CEO. And what she wanted was a tool that she had seen previously in a different organization in Epic that you could see. You can go to one place and you could see all the volumes in the organization on the inpatient side, not on the outpatient side. And so we had this tool, a daily safety briefing tool, that was manual, and we collected data about patients that were in beds, patients that were coming in, and it was all manual. And at the end of daily safety briefing, we would manually upload that to My Children's in a spreadsheet, and people could go look at that. Well, we wanted to aggregate that information because it's really coming out of Epic. And so we built an Epic dashboard. It was automated. You can refresh it at any time. Easy access. If you have Epic login rights, you can go there and see it. It's consolidated. You can see what's on the inpatient and the emergency department, what's coming through the OR. It gave you a little bit of information on what's happening even tomorrow in the OR. And minimal maintenance is needed. So here we took something that was not automated, was very manual, that had limited access, and made it so that it had much greater access, and it was automated. So that was really good, right? Because it reduced manual intervention. It increased the accuracy of the information. Remember, if you're using a static report, once you've written the number down, it's no longer necessarily the same number as what's happening after that. So we have consistency. It's easy to use. And then, like I said, anybody with Epic can see that. And we just extend now what we call operations safety briefing to think more about what are the harm events that we need to make sure we disseminate across the organization. So that was a little one, but we've done a lot of other aggregation, and if you log into Power BI, you can see a lot of different things that we're doing. The next stage is that centralized data repository. So that's the electronic data warehouse, and we did not have one. People thought we had one in a tool called Caboodle, which is a database from Epic. Unfortunately, Caboodle cannot consume anything external from Epic. So it's not a very good electronic data warehouse if all it can consume is a single data source. So our previous state was independent data sources. They didn't talk to each other. So your badge, your BioVigil badge, NRC, our patient experience stuff, Epic. It was hard to customize reports. We did a lot of work in ClickView and a lot of work in Excel. But there are better tools out there for doing calculations and whatnot. It was very difficult to consolidate data, to put two different data sets together to start to see what was really going on in systems. And then there was a lot of different manual reporting systems, including Slicer Dicer, which works out of Caboodle in Epic. We had Webby reports. We, of course, you know, Excel should be everywhere because that's a lot of what we used here at Children's. But we built a new system, and we named our electronic data warehouse Liberator. And why is that? Because Chanda was given a talk to the board, and she said early on in her tenure here, which started in September of 2020, we need to liberate the data. And that's why we named our electronic data warehouse Liberator. And Liberator can consume anything external. So it was built that it can consume all of that BioVigil stuff, all of the NRC stuff, all the Epic. Now it can consume Oracle as well. Then we build out data marts. So there's a data mart for finance. There's a data mart for HR. There's a data mart for care transformation. We have different projects that have different data marts. And then our visualization tool is Power BI. Why do we use Power BI versus Tableau? Because Power BI is part of the Microsoft 365 suite, and therefore we've already paid for it. So the idea here is we built it with SSIS, SQL Server Intelligence Services. We can move all kinds of files into Liberator. We have a structure because of our data governance processes and policies of how our naming conventions are, how everything gets moved in and calculated. We use the same thing. So, for example, ages are all the same. In every one of our data marks, you use the same type of ages throughout any of the programs that we use. You don't get to choose that I want only ages. You know, I want to call a neonate 0 to 27 days or 0 to 29 days. It's 0 to 28 days. And so that's the convention that we have used. That's what you're going to get. We consolidate that data. We can connect data marts. So we have consistency, accuracy, one source of truth now, and we have one reporting tool. And in a little cartoon, this is what it looks like. These aren't all of the sources that it consumes, but it does consume very many. And I will go through some examples of how we've used multiple data sources for a single report that you can view in Power BI. All right, so we've moved through Tier 2. I'm going to digress just a bit and go back to 2019 and 2020. those of you who remember, we were going through at that point a search for a new CEO, and our interim CEO was putting together a 2021 to 25 strategic plan. So we were assembling multiple focus groups. We probably met with over 1,000, 1,500 people in the organization with our partners around the community. And we had a lot of focus groups to come up with our strategic plan. And one of the items for our strategic plan was to get to stage 6 HIMSS analytics maturity by 2025. So that's why we're walking through this model to say, where are we? So we need to move into efficient, consistent internal and external reporting. And this is one of the things that we started with. Dr. Sato's going to appreciate this. This was a report that came out once a week. It was assembled by the lab. It looked at the isolates that we tested and then the positivity. And it came out in a PDF of an Excel report. So you couldn't drill down on it. You couldn't do calculations. It was a PDF of an Excel report, which just frustrated me no end. Had no visuals, no customization. It took somebody 4 to 6 hours every week to put this together. So we said, let's do better. And what we did is we said, look, the information's there. It's already in Epic. Why don't we just bring it into a report? It can look just the same, and we can do the calculations so you don't have to do that in your head or on Excel. But more importantly than just seeing that report is you get visuals. And so can you make much out of that? Is there any trend there that you can see? We tried to do a little highlighting with the blue to say, here's the percentage that are positive. So you have a little bit of visualization there, which is much different than that thing that didn't have any help with your visuals. And so we put together this one. And what this shows then is it's just a timeline over many, many months. And you can see the black line there, that's RSV. And RSV was coming down last November, December, while influenza was going up. And then you have these months and months and months of nothing until you start to see a little bit of RSV coming up. And back here, when I first saw it coming up, it was the first week of October. I said we were going to peak RSV in the second week of December. Look at that, second week of December. And that's the third week of December. So you can use this for predictive analysis if you want to. But it's much easier to see what's going on in a graphical form than it is in that table form. So we reduced the time to process that from 4 to 6 weeks to it's automatic. It just runs every Sunday. It pulls data, brings it up, and sends me an email that the new data has been brought in. We added the graphical review. And then you can go in there and you can actually add or subtract different viruses or bacteria that's on the list and see what they've been doing over the last whenever. It goes back 5 years, so you can look at that. And we'll do enhancements as people want to do that. But one of the great things about this project is we gave 4 to 6 hours every week back to the lab. So if you think about that, 4 hours is a 0.1 FTE. All right, so we gave 0.1 to 0.15 FTE back to the lab to do whatever they needed to do. And that's the way we've been thinking about repurposing the manual people that were doing stuff in our organization. This is an even better example. So ongoing professional practice evaluation has to be done by a hospital on every provider, every member of the organized medical staff. And we had a person, this was their job. This was their full-time job, was to assemble reports. And if somebody comes in and they're up for renewal, their application is up for renewal, used to be every 2 years, now it's every 3 years, they have to have an OPP report every 18 months. And so the medical staff office is doing this, and we have 550, I think it was 537 last month, active medical staff. So we're doing a lot of these every year. Very manual process, very, very manual process. And so what we did is we said, well, we can take information that you're using. We've got it here. Let's build our own report. And so we did that. And we added additional stuff in there as well. which was pretty cool because we could go into our risk tool and say, have you had any peer reviews during this last 18 months? And we can pull those up. And so this was all automated, and there was very minimal maintenance that was needing to be done. And so we took that full-time FTE, which was previously in the Quality and Patient Safety Department, and we moved them into Medical Staff Office, and now they're the peer review coordinator. That's the FTE. The person that used to do that moved from performance improvement or quality and patient safety into care transformation, which I run that group. So that's an analytics person. So I got to another FTE to help us build reports, and Caitlin's actually wonderful to have on the team. So this is the way we're thinking about automating stuff. So don't be afraid that AI is going to come and it's going to put you out of work. If it does, it probably should. We will find work for you to do. Like I said, we did a lot of work in ClickView. This was a ClickView report. It was the primary care practice wanted to know where they are relative to their budget at the clinic level as well as the individual level. Why is that? Because the compensation plan for primary care is based upon productivity, and they want to know how they're going to get paid, and this is the way to do that. They could see how many patients they saw. It was a static report. It had limited visibility. There were no visuals, and it was really hard to update it because you had to find Jared in order to update this. By the way, ClickView was pretty expensive. It was about $75,000 a year. So what we did is we did all of this in Liberator and then used a Power BI tool. So it was automated now. It was a dynamic report. It was easy to access in Power BI, a consolidated view with minimal maintenance because everything, we knew where it lived. It didn't break. So the good things about that is we had enhanced functionality. Now we could bring the budget in for urgent care. We couldn't do that before. We had virtual visits that we could bring in, and you could easily see trending because we could take those data and manipulate them in any way that the end user wanted to see. Easy to use, and then we had a lot of other visuals, and we got to get rid of ClickView in 2022. So we didn't pay for ClickView after 2021 because everything, all the reports were brought into Liberator. And so this one we haven't changed much in the last 18 months. All right, we're moving up the map. We're going to move towards stage 4, which is measuring and managing evidence-based care, care visibility, and waste reduction. We do pathways in this organization because it standardizes medical decision-making, and that standardized medical decision-making usually reduces waste. However, if it doesn't reduce waste, it allows the leaders of those pathways to do a deep dive into what are the leverage points that you could affect that may reduce waste. And so that's why we have a lot of pathways in our organization. The important thing about pathways is measurement. You need to measure the outcomes or the processes in order to see if we've made a difference. And for our asthma ED pathway, one of the goals was to reduce chest x-rays. And so what they did is about every quarter, there would be a manual report that they would go out, and from the ED, a patient that was discharged with asthma, they would look, did they get a chest x-ray? And if they did, they'd do a tally, and they would send that tallied information back to the providers and to the chief and say, here's who's getting chest x-rays. You may want to talk to them. We can't tell why they did it. And so we thought, well, we could probably do better than that and have a lot of other measures as well, like how long does it take to get steroids in from admission? How long does it take from when you want to admit them to the floor to actually get a bed and things like that? And so that's what we did. We built a bunch of pathways into Power BI. I think we have 12 as of December 31st. It's very dynamic. We pull them in either every week, every month, or every quarter, depending on the volume that we expect. So asthma is one that's going to be a high volume, so we can bring stuff in every week and for sure every month. But if you have musculoskeletal infections, you're not going to have a lot of those. So those are about every quarter that we go out and look. So, everything's automated in pulling this information in. You can drill down as you want, and obviously minimal maintenance because we're working on a Liberator in Power BI. So we have report optimization. There's a lot of dynamic capabilities in there for drilling down, filtering. So you can go in, you can see a lot of visualizations, how things interact, and then it's just easy to understand. For those of you in this room, most are younger than me. In fact, I think everybody's younger than me. So you're very facile with information tools. So this got us thinking then in the end of 2022 about data literacy. And so I embarked on a journey to identify a curriculum, if I have to build it or buy it, to teach people how to use data. And luckily, I stumbled onto a company called Data Literacy out of Seattle, husband and wife team. He worked for Tableau. Tableau is a visualization software tool, and she worked for Amazon. And they put together this course, and it was great. It was exactly what I was looking for. I don't know if any of you have done curriculum development, but it's fun. But it has a pre-test. It then breaks down 8 modules. Each module has a quiz and then a post-test to see how you did. And if you pass the post-test, you get a certificate. So I thought that was pretty good. I did that. It was very long. It took me over 4 hours to do the course. And then I bought licenses and put teams through that. And everybody said the same thing. The content was great, but it was too long to deliver. So I worked with them for the next 8 months, and we were able to get the content delivery down to less than 90 minutes. But the same thing, and so you can take a pre-test, post-test, and so that's going to be available to the organization. Anybody wants to take that data literacy course, and you'll see that in my future slide. All right, what about security? This is one that I'm very proud of the team that did this. Access control is in a variety of places. So it can be at the report workspace level. So we can give large groups based upon your role. So you might be a supervisor. You might be a VP. So that could get you access as the role, R-O-L-E. Then at the workspace, you can still have limitations on what you can actually see at the report level or at the application level. And then there's also within a report what you can see. So a good example is the OPPE report, or another one is the CSP, which is the Specialty Practice Plan and Incentive Plan. So there's row level security, ROW, which is in a database, there's a row. So we can limit each row of what you can see. We can do it by the role, we can do it by the report, we can do it by the app, we can do it by the workspace. So our ability to limit what you can see is very robust. So that incentive plan dashboard for the specialty, well, an individual endocrinologist can see their own report. I, as the chief, can see all of their reports, and then Alan Tingley, as the president of CSP, can see everybody's reports, including all the chiefs, because that's his role, is the president of the practice plan. So our security is very robust inside of Liberator. All right, we did some work around evidence-based care with our pathways, care visibility, and then waste reduction. I didn't show you a lot about that, but know that we have decreased a lot of things. So of the 6 pathways that we had in Power BI at the end of 2022, 4 of the 6 had reductions in outcomes by the end of 2023. So that was pretty cool that standardization does improve care and eliminates waste. So level 5, stage 5, remember our goal for 2025 was stage 6. So if we can pull this one off, we're doing pretty good. Enhancing quality of care, population health, and understanding the economics of care. So when Dr. Camille Hancock-Friesen was being recruited here, she's a cardiothoracic surgeon, she said, Chris, I need some informatics tools in order to do my job. And I said, well, we're building Liberator. This was back in 2021. We're building Liberator. It's going to be able to do a lot of things for you. We are not as robust as maybe where you came from in Dallas, but you can help us build this tool. Remember, we built things on use cases, so this was a decent use case. And so she said, I need this variable life adjusted display, VLAD, for risk adjusted survival. And this was very difficult. We didn't have any tools in Power BI that could do this kind of analysis because this is a very complex formula or mathematical equation. So I enlisted the help of the data scientist by the name of El Kearns to come in and write a program in R that pulled all of this information and then populated that into this report in Power BI. And I'm not going to go through all the details, but suffice it to say that this looks at the stat level of the patient, which is the color, and then it goes up if it's a survival, and it goes down if there's a death. And what it can tell you is based upon their adjustment. So you can see that the length of the down is based upon the severity of the patient. So this patient probably wasn't as acute as this patient or the stat level. And so it can tell us how are we doing over time. But you can see we've had multiple deaths. The other thing that it can tell you is there a moral dilemma that could be going on because of the multiple deaths over a short period of time in our CICU? And if that's happening, what do we need to do to the team? How can we go in and help the team? And then, as you can see, that we've not had any deaths since right before, I think it was late October. The other thing we built the Heart Center is these graphics. Tim LaRue did a lot of this work. And what they have started since July of this year is having continuous multidisciplinary assessment of performance. So every week they go over the patients that that were in the CICU, and they have this sort of process that they look at. So they have the operation, they have how long they were intubated, if they had another operation there, what happened. So you can come over here and you can see that there's procedure, intubation, extubation, step down to discharge. And they talk about the assessment of what's going on. So they really get to learn what's going on with the patient's course over time and how they can improve things by seeing these visuals very easily. I can send you this, Alice. You don't need to take a picture. You can have this. I'll give you the whole thing that Tim sent me. All right. Is this the one, Kelly?
It is the video one.
This is the video one. Okay. So Dr. Dolter embedded a video in this one. Uh-oh. Am I going to be able to do this? Sarah, you might have to come up here. Help me. So I don't want to screw it up because the video was so good. Well, it's not a video. It is. It's a voiceover video.
See him? Okay, so let's press out when you're ready.
Okay, here you go.
When a provider orders heated high flow in Epic, they are prompted to answer a question as to whether or not the patient is on the heated high flow pathway. If they click yes, they must answer another question, this time to certify that they have completed the heated high flow pause prior to initiation of the high flow. If they click yes, no further action is needed and the order can be placed. However, if they click no, they must cite a reason that they are deviating from the pathway.
So that's really important as you're collecting information on compliance or adherence with instructions. It's great to deviate from a protocol, an algorithm, a pathway, if you're doing it for a good reason. And that's why you want to collect the reason for the deviation, because we all can learn why you deviated. And then that can become a reason to allow it to be deviated. And so that's what we built into a lot of our pathways now. We went into Agile MD, which is a new program for those of you who've worked in the ED. You've probably seen Agile MD pathways, which I hear are pretty cool to work with. I've not worked with them yet. So as you can see, we've got these prompts, and they may bring up different prompts because we want to enhance the quality of care right in your workflow, right there. So we don't want to have you going and clicking on a bunch of other tabs if we don't have to. And then this year we've been able to bring in our costs. So we have a activity-based cost accounting software. It's called Strategaz, and it gives direct, fixed, and variable cost, indirect, fixed, and variable cost. So there's 4 buckets. There's assumptions on what goes into different buckets. And so we're specifically looking at Agile MD integration into Epic. And this is what we found out just last month, which is the biggest bucket of costs come in, oops, wrong one. Glad that didn't work. Come in this bucket, which is called emergency room. It's not as much back here, which is in respiratory, not as much cost. This is for the last 6 months for patients that were on the Agile MD pathway. Very little in pharmacy relative to the emergency room. So we need to figure out now what all goes into the emergency room bucket, and then break that down to really understand what are the leverage points in decreasing the cost of care in the emergency room for patients that are discharged from the emergency department. That's this group of patients. But the cool thing is that we have now all the costs for everything that we do in the organization inside of Liberator. And so we can connect that to all of our pathways. Anything that we can do, we have the costs that are associated with that. That's not charges. So for those of you who are not as familiar with healthcare costing, we set a charge based upon the mysteries of the universe. And then we negotiate with commercial payers of how much of a discount we're going to get from that charge. And then the government says, well, this is how much we're going to give you regardless of what you want to charge. And so there's a lot of assumptions that are going on in here. And that's why understanding your true costs to deliver care in those 4 buckets of direct, indirect, fixed, and variable cost is extremely important as you're going to manage the business of medicine. So as you can see, using this analytics maturity roadmap, we've been able to move from fragmented point systems up through stage 5, enhancing quality of care. We haven't done as much with population health, but we're able to understand the economics of care. And it's really positioning us quite well to be able to move to that next level, which is clinical risk intervention. So how do we get upstream and do predictive analytics? So that's the future. I talked a little bit about our data literacy curriculum. And if anybody's in here is interested in taking the course, please reach out to me, and I'm happy to get you set up to do that. I've been partnering with Philips and a company called Ediometry to try to get almost real-time information from our monitors. Remember, I did this 20-something years ago at a different place, Philips monitors, but we had a different system back then. And having a tough time. I think we're going to be able to do it with Ediometry. The use case, so I'm a former ICU doc, is for patients that are in the CICU on an epinephrine infusion. Can we manage that? Can we tell them when to go up on the infusion, when to go down on the infusion, when to give a bolus of saline because the CVP is low and the heart rate's up? And again, the goal is to maintain appropriate parameters for the blood pressure. And then we'd expand to other entities, other drips, other infusions, other measurement management systems. The other thing is we're converting the tiered classroom over in Indian Hills East, first floor, into a command center. I call it the Watchful Eye program to capture external inputs. We'll start at the hospital level. We'll actually start in the ICUs to be a second set of eyes to be able to run background algorithms so we can see what's going on with patients, catch a deterioration before it happens. And so that's where we're going to start moving forward this year. That remodel is going to start pretty soon because eventually we need to get into the bigger population health, the bigger predictive analytics, which is keeping patients out of urgent cares, out of ERs, out of hospitals. So think about asthmatics. Can you provide information to them about their triggers? For example, is it mold? Is it ragweed? Is it tree pollen? And we have those sensors across Omaha. We need to tap into that. We need to be able to say in your geocoded area that we know that you get triggered by ragweed. We see ragweed starting to go up. You got to make sure you're taking your preventive asthma medications. And so that's where we need to go to get to predictive analytics in the future. We will have wearables. We'll have wearables in my lifetime, I'm sure, that can get feedback to people, to systems, to AI systems that can feed that back to parents or children with the goal of keeping them healthy. Put us out of business. RSV vaccine is here. We'll see what it does next year. It didn't help that much this year. And with that, I will thank everybody that's been involved in this journey, the Care Transformation Department, Pathway Steering Committee, Clinical Effectiveness Team. It's been a lot of fun over the years, and we got a lot more fun to come. I'll take any questions that you might have. Okay, how about any response to what I just mouthed for the last 47 minutes?
So how do you move forward on population health?
Population health is about a use case. So I've done that work did that work in asthma in Utah. We had a team that we built what was called an e-asthma tracker, and we were collecting that data from the different monitors. So we had a lot of smoke in Utah. And so we had a way to alert families, and we saw that they did less urgent care, less emergency department. And so if there's a use case out there, let's bring it. So Casey's doing some home monitoring with asthmatics. That could be a good one. We've got home monitoring with our single ventricle patients. There's another good one that we can do initially. It's all about having an idea and bringing it forward, and if it costs us a little bit of money, we can find that. Wow, I didn't know it was that boring.
Does the system link up with like state? Like, is there a way to collaborate with the state?
Only if the state will allow us to consume their data. Yeah, right now we have no state data because they don't see us having a need for their data. I've specifically asked about the foster kids, the foster program, so that we can help our team with scheduling and then have a two-way system so the caseworkers from the state know when they're supposed to be coming to an appointment with us and our different specialists. But right now, that's still a discussion. But that was a use case, foster program.
There is a question in the chat. How do we work to get more access to data from the state? We don't practice in isolation.
So one of the entities that does get state data is called Sync Health. And I complained to the Dean of Public Health College that I've had a challenge getting data from Sync Health before. And so his response was, why don't you get on their board? So as of this month, I'm on the board of directors of Sync Health, and with the primary goal to be able to get some data from Sync Health into Liberator, and so that we can start asking questions of Sync Health data.
Congratulations.
Excellent.
I love that.
Well, all right. You guys have a great day. It's supposed to snow on Monday, so that'll be fun. Enjoy.